Executive Pastor of the Philadelphia Baptist Association, and it's our pleasure to welcome you again to a conversation with Dr. Thomas Farley, Commissioner of Health for the City of Philadelphia. This is our third in a series of conversations with him. When last we spoke, he said that he wanted to come back and talk to us at the point that when we got to the point of distribution of the vaccine, so that we can know what's going on and what we can do as members and leaders of congregations, pastors and clergy and deacons and chaplains and all of you all who are there. What role can we have? How do we help? What information do we share? All those kinds of things will be a part of our conversation. We have collected your questions. We have about 19 questions, some of which we will ask. We won't ask questions that Dr. Farley covers in his comments, but just be aware that we are going to get to your questions. There is a chat available, and if you want to put something in the chat, I'll be able to see it. And if it's a new burning question or something I think is really a great question to ask, and once we get through it, the question and answer period, we may have a chance to do some additional questions. With us today are, of course, Dr. Thomas Farley, Dr. Julianne Burns, and Reverend Maria Lewis, who is the moderator of the Philadelphia Baptist Association. So at this time, we're going to ask Dr. Farley if he will begin his remarks, and when he's finished, Maria will start the questions. Thank you so much for being here today, and we do hope that this is a helpful forum for you.
Great. Thank you so much, Reverend McJunkin, and thanks everybody for the chance to talk to you all. As we said, this is not the first one of these sessions, but I think maybe the most important, because we're now really approaching the time when vaccine is available to people, and it's important for you to know how this is being made available. It's important to us for people to be vaccinated, so that because I do think that's not the only tool we have in this epidemic, but the most important tool. First, let me just talk about the epidemic for a minute. We have gone through in this winter the worst period of this epidemic, with our case rates at one point over 1,000 per week, and that we had about 100 deaths per week. Been a pretty rough winter. That is on the wane right now. Case rates are going down. I'm glad that they are. They're still pretty high though. They're over 300 cases a day now, and we're getting maybe 60, 80 deaths per week. I'm hopeful that these trends will continue, and as they continue, we will gradually be easing back on some of our restrictions that we have on social distancing. I think for a long time, probably the whole rest of this year, we're going to ask people to wear masks when they're around each other, but we will gradually allow more people to get together indoors under careful conditions. So I'm happy to answer questions that you have about that with regards to your churches, if you're interested in that. But let me get on now to the vaccine. So the vaccines, we have 2 of them available. They're very effective. They're about 95% effective at preventing infection. That's wonderful. They're each given in 2 doses, and they were actually very similar in many ways. That's the good news. Now, the bad news is that we're only getting about, at least so far, 20,000 doses per week for the city of Philadelphia. Now, the city of Philadelphia has a population of 1.6 million. We have 1.2 million adults. If you take 20,000 doses into 1.2 million adults, you can figure out that's about 60 weeks in order for every adult to get vaccinated. Now, I don't think it'll take 60 weeks, because I'm hopeful that we will get an increase in the number of doses, and we've had some increase just in the past week. And I'm hopeful in the future we'll get more. But it does give you a sense that this is going to be a long process. And when the vaccines first came out, they were rushing to get them out there one day sooner, and get sort of almost set up an expectation that, in a matter of a month, we're going to be done. Everybody would have their vaccine, and the epidemic would end. It's not going to be like that. This is going to be a very long slog over many weeks to make the vaccine available to different people. And because of that, we have to set some kind of priority list on who should get the vaccine first and who maybe should wait. If we just have it be a free-for-all, then probably the lowest risk people would be vaccinated first, and I don't think that's where we want to be. So we have set up 3 goals to what we're doing with the vaccination initiative. First, to get the vaccine doses that are available to us out as quickly as possible. Second, to get them into the people whose vaccination would save the most lives. So that's either because it'll protect them or because it'll protect the people around them. And the third, to do it with racial equity, because there's a natural tendency for people with the least resources to not get to the front of the line. And if we don't do that explicitly, then we're going to under-vaccinate people who are African American and other minority groups. And we're already seeing some of that problem. So those principles, what we've done, we've set up a series of priority groups. There's 1A, there's 1B, 1C. You've probably heard about that. 1A is healthcare workers and people who live in nursing homes. We are mostly, but not entirely, through vaccinating the people in 1A. We're now in 1B. 1B includes a variety of what we're calling frontline essential workers. So people who are exposed to the infection by the nature of their work, and in turn, they can expose other people who are vulnerable. And then there's other people who are greater risk because of their age or their medical conditions. Particularly people over the age of 75, or people under the age of 75 who have medical conditions like cancer, immune deficiency, diabetes, or chronic kidney disease. There's an awful lot of people who meet those definitions, but it's not everybody. So those are the people who we feel like can, if we vaccinate them, that's the way we can save the most lives with the current wave of the epidemic. So now, how are we making the vaccine available? Vaccine has been given to, the way that we do it at the health department is we distribute the vaccine to different healthcare providers who in turn vaccinate people that they can bring in to be vaccinated. So we're giving it to hospitals, to clinics like federally qualified health centers, to pharmacies, and we have some of our own mass clinic sites for immunizations that we are running, and some of these other organizations like hospitals and the Black Doctors COVID Consortium are running their own mass clinics. In addition, we have some small teams that are going out to some facilities, and we have some large employers we're just giving vaccine to, and then they're vaccinating their own employees. So how are they making those doses available? Well, the hospitals are now taking people who meet those medical criteria, and they identified in their electronic medical records, and they're inviting them in to be vaccinated. So they're inviting people over the age of 75. They're inviting people who have chronic medical conditions who are under the age of 75. Likewise, the federally qualified health center and the health clinics are doing that. The pharmacies right now are making doses available to people over the age of 75. They don't have the medical records to be able to really demonstrate that they have these other medical conditions. Now, I should say the hospitals have been doing this for about 2 weeks or so. The clinics, maybe about a week or so. And the pharmacies are really just kind of getting going. So this is all very new. It's changing day to day. And the mass clinics that I'm talking about, where we might do 500 people in a day or more, those are mostly off in the future, but they are planned. So we do plan to have, we announced today that we will do at least 3 different sites, one in North Philadelphia, one in Juniata, one in West Philadelphia. And we'll continue to do sites in neighborhoods around the city, as long as it's necessary. Our mass clinic sites will start the week of February 22nd, the week after next. So getting to the key question of, okay, how do I get vaccinated? That's the question everybody has. How do I get vaccinated? I wish I had a clearer answer than that, but then what I'm going to give you. But here's what we could say, is that you're likely to get vaccine offered to you by your healthcare provider, like you're a doctor that's taken care of you in the past, or a clinic that you've gone to, or if you are a frontline essential worker, your workplace. And if you feel like you're not going to get that and you want to make sure that you're notified of opportunities, there is a database on our website where you can go in there and very easily put in just a little bit of information. And then we have your name. We know that you're interested in getting vaccine, and we will contact you when these opportunities arise. That website is www.phila.gov/vaccine interest. So it's www.phila.gov/vaccine-interest, one word. And if you don't have internet access, then you can call 311 and you'll be routed to the health department and somebody could put in your information for you. Or if you want, one thing churches can do is if you have some members who have internet access and some members who don't, the members who have internet access can put in the information of the members who don't and help each other out. And that would certainly help us out because there's only so many, call people we have. And then as long as you have a telephone, we will be able to reach out to you when the opportunity arises to be vaccinated. And so you may get a phone call or you may get an email, depending what you put in there, we'll contact you either way. Now, once you're in that database, just be aware that it may be a long time before we get back to you. Again, this is a multi-month process, and we're going to get back to you according to your age, your medical conditions, and to a certain extent, where you live, because that gets to the racial equity piece. One thing we know is we are under-vaccinating African Americans, we're under-vaccinating Latinos, and people in other minority groups. Not entirely clear why. Some of that is due to them being more appropriately suspicious of the medical care system and not trusting of this vaccine. Some of it may be decreased in access. We want to work on both of those. So when we go into our database and invite people for vaccination opportunities, we're going to oversample those zip codes where we know people are being under-vaccinated. So if we know very few people in this zip code have gotten vaccines so far, we want to make sure that they have an extra opportunity to be vaccinated. Because if we have any neighborhood where we have low coverage of vaccine, then there's more opportunity for the virus to spread in that neighborhood. So that's how this is going to roll out. It's going to continue to change week to week as more vaccine rolls in and more opportunities to get that vaccine are provided. But the central database will continue to be there. So trying to think what else I want to cover. I guess finally I'll say we're right now deploying these two vaccines that are very similar. There are more vaccines that are being tested and that are likely to become available. There's at least one vaccine made by a company called Johnson & Johnson that will probably become available around March 1st. That has an advantage that it's only a 1-dose vaccine instead of 2 doses. And it does not need to be frozen. And so it makes it easier for it to be stored in a variety of different clinics. And so it can be deployed in more places. It does have a disadvantage that it looks like it's somewhat less effective than the other vaccines. Maybe protects against serious disease 85% of the time instead of 95% of the time. Still a very good vaccine though. So when the Johnson & Johnson vaccine comes out, I would still recommend, if that's the only vaccine you have available to you, I would recommend you take it. You can choose to wait for the other vaccines that had 2 doses if you want, but I would suggest these days take whatever vaccine becomes available to you. And if you want more detail about that, Dr. Burns, who's an infectious disease specialist, can help answer these questions about the vaccines themselves and their effectiveness under the current environment. So that's where we are. I'm going to say, I know many people want the vaccine, can't get it, and are frustrated by that. I hear that. I am sympathetic to that. We are doing everything we can to get it out there, but it's going to be a long, and ultimately everybody will have their chance, but it is definitely going to be a long process. And because there's still a lot of unknowns that we can't provide all the information that people want to have at this point, and we'll just make it available as we have it. So let me stop there and see what questions that I should answer from ones that were submitted before or that people submit from the chat.
Well, thank you for that, Dr. Farley. Very informative and very helpful as we think through how we can support our church congregations and our community as a whole. Dr. Burns, thank you also for joining us, and looking forward to both of you helping us to answer these questions. And before I start the Q&A, I just want to take a moment and thank Dr. McJunkin for thinking much of our community of the Philadelphia Baptist Association and putting this together and always just being on the front line and thinking forward and helping us. So thank all of you. So with that in mind, let me just go ahead and get started with the questions that have been previously presented to us. We did, Dr. Farley, hear from you just now speak about some of the impediments with regard to the distribution of the vaccine, particularly in Philadelphia. Can you help us understand what may be done at the federal, state, and or even the local municipality level that offer support? Is there connectivity among these levels of government?
I would say that in the previous administration, we had great difficulty in, communicating and getting people to appreciate the situation we were dealing with here at the local level. We have a new team at the federal government, and I'm feeling much better about that. And they certainly understand what our needs are. There's a limit to, they can't make vaccine magically appear. So there's a limit to what they can do there. There is one issue that we have to deal with here in Philadelphia, and that is that vaccines are allocated to cities like Philadelphia based upon the resident population. But Philadelphia doesn't just serve people who live here, we also serve the people who work here. So a lot of the healthcare workers we vaccinated live in other counties. So in that sense, we're actually getting fewer doses per capita than some other places. And so we have, asked from the federal government to somehow compensate with us. We're happy to vaccinate people who are not Philadelphia residents, but then we want more vaccine for the residents. So if you're dealing with the federal government, if you could send that message that, maybe they should base it upon the daytime population and not the resident population. But otherwise, I'd say that our cooperation is quite good now between the federal government and the state government. And, the fundamental issues of there's only so much vaccine to go around, and it takes certain time just to set up processes to get out to people. That's a reality that is going to unfortunately frustrate us for a while. We will get past it for sure, but it's going to just be a step-by-step solution.
And thanks for that. And you had mentioned that there are, over the past few weeks have been about 20,000 doses per week distributed. Do you have any framework of knowing, what lies ahead in the weeks to come based on what the federal government has outlined?
Right. So we, this week, we got 24,000 doses. And then a new federal program added another 4,000 or 5,000 directly to pharmacies. So we're approaching 30,000. The federal government has said that they can tell us how many doses we're going to get 3 weeks in advance, but no more than 3 weeks. So that's not enough to plan on. 3 weeks is going to come over pretty soon. And I need to know now how much we're going to have 4 weeks from now and 6 weeks from now, but I don't. And so people in the federal government are aware of that. I think that they have their own just lack of information about what the companies can produce. So that's been a problem right from the very beginning, is that it's really been guesswork. We just don't know how much we're going to get each week. And it's very hard to plan with that in that situation.
Thank you. In your opening remarks, you spoke a little bit about the inequity associated with healthcare, and particularly as it relates to COVID. We know that persons of color make up a smaller portion of those that have been vaccinated in Commonwealth and also in the Philadelphia area as compared to their overall population. Is there, I know you talked a little bit about the oversampling, the checking certain zip codes, but is there something else in place that will address specifically certain demographic groups?
Yeah, so the way that we laid out our priority groupings had that in mind. So, the people over 75 are disproportionately white. People under 75 who have chronic medical conditions are disproportionately African American, Latino. And so part of the reason why that second group is in phase 1B at all is to try to address that, to give access to those folks who might otherwise be way down the line and the opportunity to get vaccinated. Then I think our key strategy really is what I mentioned before, is now that we have the database and we're have a sense for the distribution opportunities to really oversample the people in the zip codes that are being under-vaccinated now for vaccination opportunities. Everybody will have some opportunities, but it'll be clearer for people if their zip codes are under-vaccinated. So that's the access side, and that's what we can do at the health department. There's also the issue of the hesitancy side, and that's part of the reason why this conversation is so important. I think, a lot of people at your congregations will listen to you for leadership, and they'll have a lot of questions, a lot of very reasonable questions about, is this vaccine right for me? I hope you'll learn enough about it to where you're comfortable endorsing it. And if so, that'll help people get over the hump and have them be willing to get vaccinated. And if we work at the same time on the access side and the hesitancy side, I hope we can improve our numbers.
Thanks for that. Just one or two more questions on the access side, and then we'll switch a little bit. You had indicated that as of February 22, we'll start having these mass sites, and I think you've indicated in certain areas that might reach underserved populations. Is there a process in place to determine who gets vaccinated at those mass sites? I mean, we don't want everybody showing up and then not everyone being able to be vaccinated.
Yeah, so people will be invited to schedule an appointment out of our database that I mentioned. And I'm hoping that system will work. There is a problem that we have in that technology can only do so much. And if we send an invitation and they pass it on to somebody else, who passes it on to somebody else, who posts it on the web, we may have people signing up for appointments that we didn't want to direct there. We're going to try to deal with that, but it's not impossible not possible to stop that. But yes, we're gonna, it's not just anybody show up. It's you only come there if you have an appointment, and the appointments are gonna be directed to people who sign up on our database, who are gonna be preferentially selected from those groups that we wanna make sure they get vaccinated.
Will you then require some sort of proof of residency or something along those lines? I'm recalling last week the story in New York where persons were coming into the Bronx, I think it was, maybe it wasn't the Bronx, but it was in an area that was meant to serve that community, and persons were coming outside.
Yeah, so this is a problem that everybody's having, as you saw from that story, that people are trying to get the people who are disadvantaged vaccinated, and folks who are very aggressive from elsewhere who have privilege are coming in and getting vaccinated. We could could try to put in place some pretty stringent proof for people to get vaccinated, but I worry that could work against us as well. For example, we want undocumented people to come in and be vaccinated, feel comfortable. So we don't want to have to, have extensive requirements for documentation when they come in the door. We haven't quite figured out how to do this, but we're trying to come up with a balance between making it easy for people who are at high risk to get vaccinated, and not making it so difficult for others that the ones we want to reach are also turned away.
Can you imagine there being community assistance in helping kind of have the appropriate barriers or opportunities in place, such as assistance with transportation and the like? Have there been any connections with the communities made to help out in these mass site areas?
We haven't had any concrete discussions yet. We've had a lot of discussions like this. We've talked about things, but nothing concrete in place now. I will say that the health plans, people have your health insurance from, including the Medicaid plans, are enthusiastic about assisting. And they said they would be happy to notify people, schedule appointments for people, and even provide transportation to people. So I haven't figured out how to make that work yet, but that's something which may be a really good value there. And there may be, maybe it's appropriate for churches to provide that assistance if they are so inclined.
We had talked a little bit about vaccines being available in pharmacies in the future, and I might have missed that, but is there a date certain for that, or just later down the road?
So that they are available now, and it's increasing almost every day, certainly every week. So as of today, they are in 26 Rite Aids and 11 Walgreens and a handful of ShopRites. And we're going to expand to 77 Rite Aids at the end of this week. And then there are a number of independent pharmacies that are going to one by one sort of come online and have vaccine available to them. So that's just going to continue to gradually grow. Those pharmacies are all being told now, just people 75 plus. And we're having a similar problem there as we talked about before, that the people who are over the age of 75 are not the most internet savvy, aren't signing up fast enough, but their younger people are trying to sign up and take those slots. So one thing you could do is help direct the people who are over 75 to those pharmacies, because we really want to get those folks vaccinated. We have checked our database, and just looking at this earlier today, we have 29,000 people over the age of 75 who signed up in our database. So we're going to try to help get them in, but I do think the pharmacies, over the long term, pharmacies are going to be a very important part of this whole vaccination initiative. And when we feel like we've gotten enough of the 75 plus is vaccinated there, we'll open it up to other groups.
So our clergy on a lot of levels are on the front lines, and I know that there's different viewpoints on who fits into group B, 1B. Can you help us understand whether clergy fit into that category?
They're not, I'm 99% certain they're not listed explicitly in phase 1B. I would, let me just say, I think it would be very advantageous for clergy to be vaccinated and to set a good example for their congregation. I think a lot of the clergy probably would qualify in 1B by nature of their age and medical conditions. So diabetes, chronic kidney disease are pretty common, and some people are over the age of 75. So I'm encouraging clergy to be vaccinated as soon as they can, but we don't have them called out as a specific group, I'm fairly certain, in our essential worker list. Is
there the possibility that use of clergy can be added to 1B to help promote, like you said, setting the example within the community?
We can look at it. I have to tell you, I'm involved in multiple conversations every day about another group that wants to be on the list, and they can all make very compelling cases. Every one of them is, that's a good case. And if everybody's a priority group, then nobody's a priority. So I can take that back to the group, but at least at the moment they're not there. But I do think a lot of members of clergy probably already qualify by the nature of their medical conditions.
Just sticking with the church in this moment, as you're aware, many of our churches have tried to model the appropriate behavior, whether they be meeting in person and social distancing, or in many cases have been meeting online. What type of indicators will help us know when it is safe to resume in-person gatherings?
So right now we are allowing in-person gatherings for religious services up to 10% of capacity. So if your sanctuary can hold whatever, let's say 200 people, then 20 people there, which is small, but some of the churches here are quite large. So if, I don't know, there may be some that have 2,000 and you can have as many as 200 people. Everyone should stay at a distance. Everyone should wear a mask the entire time. And I would personally discourage singing because that you get more respiratory droplets out when you do that, or, chanting, that sort of thing. So it can be done now. We're going to continue to look at our case rates. And if they're going down and lower now, then we will ease back on that threshold of 10% and raise that number, and would probably be in sync with changes to what we would have, say, at theaters. Right now, we likewise have the 10% limit for theaters.
Any data out of the past handful of months as to whether churches have seen have been we hear in the news of super spreader events, but churches that are regularly meeting throughout whether it be Philadelphia, throughout the country, any evidence that has led to increased COVID positive? Right.
So there definitely are quite a number of case reports of big spreading events at churches. So in the way that we have always held church, those are clearly high risk settings. A lot of people close together, not wearing masks, singing. And that's sort of the most dangerous setting. Now, during this winter wave, when we've hit almost 1,000 cases a day, our contact tracing work was completely overwhelmed. So the vast majority of people that got this infection, we never spoke to them. We don't know how they got infected, and we'll never know that. So a lot of infection could have occurred in churches and we wouldn't know it. Excuse me. So the answer is basically that we just don't know. I would still consider churches as the way we've always held it to be high risk. Excuse me.
Sure.
To be high risk. And so for people who want to restart in-person services, they can do it, but they really need to do it very carefully.
And in order to get kind of a full community of churchgoers back in, would we have to experience that kind of herd immunity numbers that they've been talking about nationally, whether it be 85% or whatever numbers we're talking about?
I think if you want to go back to, a traditional church service, there's a lot of people together, not wearing masks and singing. Yeah, you'd want to have an awful lot of those folks vaccinated and very low rates in the community. So I think we're not going to be there for a long time. So I think people should expect that at a minimum, we're going to be recommending masks for everybody in the service for many months, probably at least through the rest of this year.
Okay, well, thank you for that. One of the things that you identified was that there are various categories as to when people can receive their vaccinations. What about your typical person who's under 60, no history of medical conditions and is otherwise healthy? Is it too soon to tell when that group will be vaccinated, or are there some indicators?
It all depends on how quickly the vaccines can be delivered to us, but it's going to be, for those people, a long time. So I put myself in that category. I'm 64, don't have any medical conditions. I'm figuring I definitely won't be vaccinated before April and probably more like June. And so people are just gonna have to wait. And I'm fine with that, right? I'm used to wearing a mask at this point, being careful. I'm eager to get the vaccine, but I know there's many people who are higher priority than me. I would rather have them get the vaccine now.
And you gave us the website of www.phila.gov/vaccine interest. Is that correct?
That's it.
Be
Yes.
on the list. And can anyone be on that wait list?
Yes, absolutely.
Okay, so anyone can get on that, and then the government will prioritize based on your information.
Yes, that's right.
Okay. You had talked a little bit about members of the congregation having assistance by other members of the congregation. How does it help us, if you can walk through that? Is there personal information that has to be completed? How do we do that for someone else?
Yeah, so there is, the interest form is pretty simple, but it does have at one point a series of check boxes. It says, check these if you have these conditions. And so it could be, check these if you have diabetes, check these if you have, or maybe it's, I forget, it may be a list of conditions and you check if you have any of those. And a check indicates your age. So some people may consider that personal information. There is some level of that being medical information. And so some members may not want to have other people helping them with that. And I totally understand that. But other people may be okay with it. And if they are, then certainly someone else can fill it out for them.
Okay, thank you for that. So maybe some of these questions center around the actual vaccines and the efficacy of the drugs. People just want to know, we're being told that the drugs are safe, and we know that Pfizer and Moderna have their vaccines that are available now. What are the risks associated with the Pfizer and Moderna vaccines?
So I'm going to let Dr. Burns answer that question, who's more of an expert on that than me.
Sure. So as you know, these vaccines were studied in large clinical trials. So just to back up, vaccines do go through many phases of development, and from studying the vaccine in just a few persons to slowly going up to a trial which could include many thousands of persons. So both vaccines that are now available were studied in trials that included more than 40,000 people. And then these participants were followed for at least 8 weeks, some of them more. Within 8 weeks is the period of time that the scientists have determined that we would see effects, if there are going to be any, from vaccines. And there were no serious side effects seen during that period of time. And these trials did include individuals of diverse races and ethnicities, and they were about half men and half women. At one point, the trial for one of the vaccines was paused to include more diversity in the trial among participants. So based on the data that the companies presented, these vaccines did get this emergency use authorization by the FDA. The data was reviewed by an independent committee of scientists. So really had reviewed in fine detail, and this information was also publicly available for anyone from the public to review as well. So there were no significant serious side effects seen. I do want to say that with these vaccines, as we study them in more and more individuals, there is a process that the CDC has for continuing to monitor for any significant side effects as more and more people are vaccinated. And there is a very rare rate of a serious allergic reaction that could occur from the vaccine. But as more and more people have gotten the vaccine, they've determined that that is very rare. And we do take precautions in our clinics of just asking individuals screening questions to see what risk they might have of that serious reaction. And then individuals just need to wait for a period of 15 or 30 minutes after receiving the vaccine. And again, that it's a rate of a handful of cases per million. So it is rare, but that is just one side effect to be aware of. And Dr. Farley, please comment if there's other things that I have forgotten.
I think one thing people sometimes mix up between a serious adverse event and then the common side effects. So there are some very common side effects that, for those of you who know someone who's been vaccinated, you probably heard about, but you want to talk a little bit about how frequent those are and what people typically experience after they get these vaccines.
Yes, thank you. So that's very important. So after vaccination, your body sees the vaccine and mounts an immune response. So your body is making all sorts of proteins called antibodies to be able to protect you in the future. So in that process, there's common side effects, expected side effects that you can have from the vaccine. So these range from just like a local sore arm to things like just more general muscle aches, fatigue. You might have some chills or a low-grade fever, and maybe for a day or two after the vaccine. I think there's a range of symptoms that people might experience. I've heard just anecdotally, some people just have a sore arm, and then others might have these symptoms for 24 to 48 hours. So we do recommend that you just be aware that you could experience those symptoms. It might be, if it's feasible, it might be, and you can arrange it, maybe make some room in your schedule to let's go easy on yourself if you could the next day. I know that's not always feasible for some people, but again, these side effects are expected and actually good signs that you are mounting a good immune response. And so if your body sees the virus in the future, that it can respond and not make you ill.
You had mentioned these side effects, and it reminds me of the flu shot, when some people in communities say, well, I don't get the flu shot because it gave me the flu last time. Can you talk a little bit about whether a vaccine can actually give you the thing that it's trying to ward off?
No, that's an excellent question. I hear that all the time. And it's a very, very common concern. So just to step back, I do want to say that these two vaccines that are currently in use, and to my knowledge, all the vaccines that are currently in development do not have any live virus in the vaccine. So there's no virus that's in the vaccine that could could cause you to have the COVID disease. There is a small genetic code, like instructions, that will tell your body to make a specific protein of the virus. So it's a specific protein that the virus makes, that your immune response, that your body will see and react to. So there's no ability for this small code to get into, there's a couple different concepts here, but I would just want to say, so I guess I'll back up and say that first, so there's no way for you to get COVID from the vaccine. Some people have concerns about this small strip of code and whether that could change your cells in any way, whether it could cause the DNA of your cells to change. And it can't do that. So this small strip of code is called mRNA. So it's a little bit different, and it cannot get into the nucleus of your cell. It can't change the DNA of a person in any way. It just tells your body instructions to make this protein for about a week or two, and then it goes away. So there should, there's not a reason to think that you should have kind of a long-term experience from this vaccine or be able to get COVID from the vaccine. I'm sorry, I can answer some questions about those concepts because if there are others that arise, because I know that's can be a little bit confusing.
If I can just
or summarize.
Add one little thing. We frequently have heard from people say, well, I don't want to take the vaccine because I've got heart disease, or I don't want to take the vaccine because I've got, kidney disease. And actually having those medical conditions is exactly why you should get the vaccine. The vaccine works in everybody, essentially. And if you have a medical condition that puts you at greater risk, that is exactly why you need to be protected.
Thank you for that. One of the things that we're hearing now, obviously in the news, is these new strains of virus, particularly the one out of the UK, England, and South Africa, and that Pfizer and Moderna weren't necessarily testing with that new strain at the time they had their studies. Any thoughts on the strength of these vaccines as they combat these new strains?
Sure. I have tried to keep up with this myself. I know there's news every day, and so that's evolving. But the summary of what I have read from some review articles is that at least there's a strain from the UK. I'll just talk about that first, which it has been detected in the United States. Against that strain is more transmissible, so it can be passed more easily from one person to another. So it's like more contagious. To my understanding, they have done studies with people who have been vaccinated with the Moderna and Pfizer vaccines, the current vaccines that are currently in use. And these people have neutralizing antibodies, so they have the ability to combat this new variant. So I think it is rather promising, at least in the lab, that the vaccines that we currently have will be effective against those strains in terms of not making you very sick from COVID. However, it is concerning because the strain from the UK is more transmissible, and so potentially more people could get infected with the COVID vaccine and people who are not protected. Then there is the strain from South Africa, which also was not tested against the vaccines. So my understanding from some summaries and reviews is that this variant, there's a little bit more concerns about it. These changes, when they study these changes in the lab against people who have had the COVID and Moderna vaccine, they don't produce, these antibodies are less effective against the vaccine, so they have less protection. However, your body makes a very robust, a very strong immune response against with the vaccine. So it's a very strong response to begin with the vaccine. So if it was a little less effective against the variant, it still could be provide you with protection. We don't know in real life what that looks like. They're currently doing studies right now in South Africa to better understand that. So in summary, we think that you would probably have some protection from the South African variant, but we don't know what the efficacy really will be in the real world. So scientists are still studying that. I think it does emphasize that it is important when you have the opportunity to get the vaccine. If you are able to get vaccinated, you will have another layer of protection in some manner, we hope. And that will even, and also getting vaccinated will hopefully decrease the burden of virus spreading in the community and allow less room for the virus to change even further in the future. So still important to get the vaccination, even with these strains that are being identified.
The important
Dr. Farley, please add to that.
That's right. Yeah.
Okay.
Yeah, thanks for that. Along those lines, I know that the full testing hasn't been done for children, and under 16, and so the current vaccines aren't necessarily given emergency authorization for that. Do we have any expectation that will happen in the near future?
My general understanding is the studies are ongoing in terms of enrolling children in trials for the Moderna and Pfizer vaccine. I don't know the details myself in terms of timing of when that data will be available. And then of course it will need to be presented to this advisory committee, which recommends approval to the FDA. And I'm sure, Dr. Farley, if you have any other information about that.
I don't. So it's going to be probably some months down the line before if they approve it at all, before they would approve it for children.
There are many people who are, of course, waiting in line, and maybe some older family members and within even the home have been vaccinated while others have not. Are the persons that have been vaccinated, are they safe and protected from those in the house that haven't been vaccinated yet?
So at this time, we don't know if, and maybe make sure I'm answering the question correctly, but I will say that we don't know if you have been vaccinated, if you are then exposed to the virus. So you're vaccinated and someone exposes you. We don't know, even if you don't get sick yourself, we don't know if you can pass the virus to someone else who has not been vaccinated. We think that there probably is some protection, and that you probably are less likely to pass it to someone else if you are exposed. Again, you're less likely to get sick yourself because you have been vaccinated. So you are less likely to experience COVID disease, but you could still have a virus that you're exposed to, infectious, and the question is whether or not you could pass that to other people. So we think that's less likely, but scientists are still trying to understand whether or not that is the case. And so until we really have the smallest level in our community and we have herd immunity, most people are vaccinated, just it highlights the reason for the three main things: masking, social distancing, and hand washing, to prevent viral spread. So does that help answer the question?
For sure. And I think I know even based on that the answer to this, but can you get COVID a second time?
So it is rare. There have been cases that have been described, and so what can happen is that when you get COVID, scientists are still understanding the different kinds of immune responses that you can have. So some people might have more protective immune responses, and some people could have less protective immune responses. It could be potentially due to how severe of COVID they got. So potentially if they have less severe COVID, they might not have as a protective immune response in the future. And we're still understanding how long the immune protection after getting the COVID disease, how long that will last in the future. So right now, scientists say that you are protected, or it is rare to get COVID within about 3 months after having COVID disease. After that, we don't have enough information to know, and in some cases have been described of getting COVID again. So we do recommend getting the COVID vaccine, even if you've had COVID in the past, to better protect yourself in the future. The vaccine really provides a very exact, strong, and stimulus for getting a strong immune response. Whereas if you just had the infection naturally, it can be more variable. We do allow individuals to get the vaccine as long as they are not still infectious from COVID. So if your turn comes up and you have the ability to get vaccinated within that 3-month window after having COVID, then we do recommend, please discuss with your doctor, but we do recommend that, especially if you're high risk, that you do step up and take your turn if you'd like the vaccine. We just would not want you to come to the vaccination site if you currently are experiencing symptoms of COVID. If you're in that 10-day window where you could be infectious to others while you have COVID. And also if you were exposed to someone with COVID and you're in your quarantine period. So you're in your period of time that you're waiting, that you're quarantined to make sure that you don't have COVID. Because we just don't want you to expose people at the vaccination sites themselves. But other than that, we do recommend getting the vaccine. If you, if you do have the ability to wait your turn and you're not high risk, you could wait, maybe for 2 to 3 months and then get the vaccine. But we do want the most people vaccinated as soon as possible. So, when it's your turn, we do encourage you to step up and get it if you're comfortable.
Sure. Dr. McJunkin, I know there's some chat questions, and so I'll go ahead and turn it over to you.
Thank you. Some observations and some questions. One was, is there a possibility for some kind of home visit program for vaccine injections for people who can't get out?
I'm going to say we do know that there's some seniors in particular that have people who have difficulty getting out of the home. And we are looking at some options for that. We don't have anything I can tell you about today, but we definitely are aware of that problem. And I hope we can announce something like that in the future. Okay,
thank you. Another one was, we noticed that some, I'm going to use the word vendors, and by that means suppliers, people who are given the vaccines, are more creative. They find solutions, ways around access problems. And so having enough, whether it be like the doctors COVID-19 group. I also was watching television the other day, and there was a doctor out in California, very similarly, really working hard to understand where the blockages, where the distribution concerns were, where the access concerns were, and coming up with creative solutions to get information to people, to get them, to get shots into arms. So there was a concern about making sure that in Philadelphia, we have enough organizations of that nature that are going after that problem.
So if I can just respond to that, so that we definitely work closely with the Black Doctors COVID Consortium, Dr. Stanford, and she is getting as much vaccine as her organization can handle and vaccinate. And I think that she'll probably increase her vaccination capacity in the future, and we'll be able to supply her more doses. But we need many more organizations like that. And so we will be putting out a request for proposals for organizations that want funding in order to be able to provide vaccination services. And that's a slow process, I know, but I'm hoping with that process, we will have other organizations like that are able to provide those services in the community.
Thank you. That really got at the question. there's some confusion because of, uh, like Montgomery County moved, I have a notice, moved clergy into 1B.
Right.
Okay. And I know that I've heard from clergy that live in other states where they are part of considered frontline and can get the vaccine. What happens in many cases, I can live in Montgomery County, but my church is in Philadelphia, and that's the community that I'm serving and the people that I'm working with, but I can't get on the list in Philadelphia, or vice versa, where you were giving example to before about in healthcare situations, hospitals and whatever else, the institution is given the vaccine out, and it kind of gets around the problem of where you live, being locked out of opportunities for vaccine because of where your address is. I'm trying my best to interpret this question to you. Did it make any sense? Was it?
Yeah, I do. So just to clarify, we are certainly trying to use our Philadelphia vaccine for Philadelphia residents, but we don't generally have hard residency requirements. Likewise, Montgomery County doesn't. So somebody who lives in Montgomery County and works in Philadelphia may have an opportunity in either county to get vaccinated. And I would say, if you're eager to get vaccinated, take the first chance you get.
Okay. Thanks for the answer to that. And hopefully the forms, when you go on the site and sign up, don't kick you out just because you don't have a Philly address or whatever. I don't know the answer to that, but that was one of the things that came up. And so I'm just passing it on. This list of pharmacies, you talked about the pharmacies, so many, Rite Aid, so many. So if a pastor wants to be able to say to members of the congregation, these are some pharmacies in the area, where do you go to see the list to know where to tell people to go?
So the first point, just to reiterate, this is just for people over the age of 75 at this point. And so I would go to the websites for Rite Aid, Walgreens, or ShopRite at this point. Now more will come up in the future, and those slots get filled in a hurry, so that may not work. But if it doesn't work, then register at our website. As opportunities come up, we will direct you at other opportunities.
Okay. And the last question that I got was more global in nature. I guess we have a concern not just about what happens in Philadelphia or Pennsylvania or the United States. How are we doing with distribution? And we know that if we don't get the vaccines to everyone around the world, COVID will continue.
Right.
To infect.
Yeah.
Humanity. Where is it? Where is it? How are we coming along?
Yeah, so that's a good question. And it is a reality, unfortunately, that the wealthy countries of the world are competing with each other for doses of these vaccines. And the less wealthy countries are not getting these vaccines because they can't afford to pay for them in large amounts. So, people in Europe are having about as much access as we are, which is still not enough. Likewise, in the United States, but much of the rest of the world has very little. They may have some of these other vaccines that, to me, have less proof behind them. So what that means is we're not going to eradicate this virus from this earth for a long time. It's always going to be out there. It's always going to be circulating, which means that if you have an opportunity to vaccinate, you still should. It also means that as a nation, we need to figure out how to make vaccines available to the less wealthy nations around the world. And that's people from the World Health Organization have pointed that out. Hasn't happened yet, but it needs to happen.
Thank you very much. I think that could be a point of advocacy. We could participate in that as well to make sure that folks are cared for outside of the United States. And we promised everybody that we would go to 7:30, and that time has arrived. So Maria, did you have any other one last question?
Let me just throw one quick one out there, which is, do we know yet how often we'll have to get this vaccine?
I'd like Dr. Burns answer that question.
Okay, sure. Unfortunately, we don't at this time. You know, our best hope is that this vaccine will provide protection for a longer period of time, but we just don't have the data to know that right now. So I think, you know, these vaccines do produce a strong immune response. So I think it is our best bet right now in protecting us in the near and hopefully more distant future from giving COVID disease, especially those of us who are vulnerable to severe COVID infection. But we just don't know that at this time. Hopefully more information will become available soon. And you know, whether or not we need such things as like a booster shot in the future at some period of time, like there is with the flu vaccine, to make sure that you still have good protection.
Thank you both.
I want to thank you both for sharing, Dr. Farley and Dr. Burns, your time with us and your information, your expertise. It means a lot. For those of you all who are on the call, we really appreciate your being here, and we encourage you to spread the word, to tell what you've learned today, and to encourage people in your congregations to get the vaccine. You've heard some strategies and ways that you can be of assistance. And I think this has been a very good discussion. And once again, thanks to everybody. And we'll talk to you again soon. We'll keep in touch with Dr. Farley. And when it's time to have another conversation and he's available, we won't hesitate to connect with you.
Thank you very much for the chance to talk to everyone. This is really an important group, and I'm glad we had the conversation.
Thank you.
Thank you sincerely for this opportunity.
Good night.
Good night, everybody.
Good night.
Thank you, Janet.